So yeah, I'm David Lewis from Plymouth, and I'm going to talk you through practical considerations and management strategies of bispecific antibodies in particular. I'm sure you remember yesterday I spoke to you about bispecific antibodies and the current evidence for their efficacy. So we mainly focused yesterday on the efficacy and a little bit on the toxicity profile of bispecifics. Today, really, we're going to focus more on the adverse event profile in a bit more detail that you see with bispecific antibodies and how you might take steps to mitigate them and also how you manage them. And I'm sure a lot of people in this room are familiar with these already, given that you work at CAR T centres and have got quite a lot of experience in treating patients with some bispecific antibodies. So there will hopefully be, here's disclaimer and disclosures. There will be some time for questions today because this is a slightly shorter talk than yesterday, so I'm very happy to take questions at the end and talk through things in more detail. But here's what I'm going to focus on. I'm going to talk first of all about cytokine release syndrome and ICANS. I'm going to talk through how we define those entities and how we might manage them and when you might want to jump in and treat them. And then we're going to talk about mitigation strategies. So all the bispecific antibodies that are available currently have different strategies to mitigate the risk of cytokine release syndrome, and I'll talk you through those in some details, particularly focused on the epcoritamab data. And then talking about how you might set up strategies by which you can identify CRS and ICANS quickly. Okay, so by way of introduction, let's just, and I'm sure that a lot of you in this room are familiar with this, but I'm just going to talk briefly through what CRS and ICANS are before we go into them in more detail. So cytokine release syndrome is an immunological phenomenon associated with T-cell engaging or T-cell activating agents that is characterized by sort of hyper-inflammatory type physiological process. It universally includes fever, so you can't diagnose a patient with cytokine release syndrome if they're not febrile. And in its later stages includes symptoms such as hypotension, hypoxia, and organ dysfunction. ICANS is an immune cellular associated neurological syndrome, which is associated by various symptoms, including dysphagia, dysgraphia, and aphasia, as well as in more severe cases, seizures and loss of consciousness. And again, I'm going to talk you through that in more detail on later slides. First of all, classification for cytokine release syndrome. I mean, as I said to you yesterday, I work in a centre that, whilst we do a lot of clinical trials, actually certainly when we opened the bispecific antibody studies, we weren't a CAR T centre. So in my centre, we had actually no experience of treating cytokine release syndrome at the time we opened the epcoritamab study and also subsequent bispecific studies. And we were, I would say, slightly nervous actually about dealing with cytokine release syndrome in our hospital, as I'm sure a lot of centres will be when they start giving these agents. By way of reassurance, I thought I'd just talk you through this. I mean, and again, you will have seen this before, but actually the grading of cytokine release syndrome is actually very straightforward and very easy to remember. And this is the ASTCT consensus criteria, which is used both for bispecific antibodies and for CAR T-cell therapy. So for grade 1 CRS, you're talking about someone who's basically just got a temperature but otherwise well. So by definition, as I said, you have to have a temperature above 38 for CRS. So grade 1 CRS is temperature above 38 but no other symptoms. Grade 2 CRS is where patients are starting to, as well as having the fever, starting to drop their blood pressure a little bit or require some low flow oxygen. So grade 2 CRS is the sort of patient who might be febrile and look a bit like they've got a mild septic infection, but they're still well enough to stay on the ward. Grade 3 CRS and above is where you're really having to get maybe your help from your intensive care or HCU colleagues, because the grade 3 CRS is where patients are starting to require a need for high flow oxygen and possibly need inotropic support to support their blood pressure. And grade 4 CRS are these patients that we really worry about. These are the patients who need often quite intensive ITU support with multiple vasopressor support, or in some cases even requiring intubation. So in terms of CRS, grade 1 and grade 2 you can look after very happily on your ward. Arguably grade 1 CRS you could manage as an outpatient. Grade 3 and 4 CRS is really where you're needing the more intensive support. And similarly, the ICE score is used to assess the ICANS scoring system. And for those of you who aren't familiar with the ICE score, it's actually very, very straightforward and takes less than 2 minutes to do. The scoring is written at the bottom here, and you can just go through it with your patient, or a nurse on the ward can go through it with the patient in less than a couple of minutes. It's simply asking patients if they know where they are, if they can name 3 objects and follow commands, count backwards from 110s and write a standard sentence. And we found it very useful to establish what the patient's handwriting was like at baseline, because certainly I would almost certainly fail an ICE score with my handwriting on a good day. So I think it is important to establish a baseline for what your patient's handwriting looks like before you start the treatment, so you can actually pick up early if they're starting to get handwriting problems, because that tends to be one of the first things that goes when patients get ICANS. And the scoring system's written here, so the grading of ICANS is based on the ICE score, but actually you can get higher grade ICANS automatically if you're starting to drop your conscious level, and particularly if you get something like a seizure, that automatically gives you at least a grade 3 ICANS. Okay, so cytokine release syndrome really came to the forefront of everyone's minds because of the high rates that we see of cytokine release syndrome with CAR T-cell therapy. And I think the advent of CAR T-cell therapy into standard of care in diffuse large B-cell lymphoma has really focused people's minds on these sort of toxicities. And you can see that with the currently available CAR T products, you see cytokine release syndrome in the vast majority of patients who get axi-cell, and similar high rates, although lower with lyso-cell and T-cell. It's really, I think, the things that everyone worries about with cytokine release syndrome are these grade 3 or 4 events, and these are the patients that need intensive care support. So you can see with axi-cell, you're sending, in some studies actually, up to about 20% of patients to ITU for support. You can see that in terms of when it starts, it tends to start a few days after the CAR T-cell product, and it can take some time to resolve, up to a week for CRS resolution with the CAR T-cell product. So it was for this reason that everyone was slightly anxious about doing bispecific studies, because we were all concerned that we were going to see similar patterns when we opened our bispecific studies. But actually, our experience, and in fact the experience from the data reported, is that whilst you do see cytokine release syndrome with bispecific antibodies, there are 2 things that differentiate this from the CRS that you see with CAR T-cells. First of all, although you see it in about 50% of patients across all the different studies that are available, you only see the grade 3 or 4 events in a very small proportion of patients. So you're only needing to involve ITU in a single-figure percentage of your patients on bispecific antibodies. And in fact, with the epcoritamab study, there were no grade 4 CRS events in the entire study of over 100 patients. The second thing about CRS, which is different from CAR T-cells, is the time of onset tends to be very quick and predictable. It tends to be usually within a day of the first full dose of the bispecific antibodies. Now, the exact time of that first full dose does vary slightly from product to product. With epcoritamab, that first full dose is on cycle 1, day 15, and as we'll see in a minute, that is the most common time point for the development of CRS. So it's usually low grade, it's usually predictable in terms of time of onset, and the other thing is it tends to resolve quickly. So whilst you see cytokine release syndrome with bispecific antibodies, it's usually lower grade and has a predictable time of onset quickly after the first full dose with bispecific dosing. So there's the epcoritamab data, and again, just to highlight this in more detail, cytokine release syndrome in the GENO-1 study, which is the epcoritamab study I spoke through yesterday, is usually low grade and predictable, and the vast majority of CRS events occur following the first full dose. And this slide that I showed you yesterday illustrates that. So as I'm sure you remember from the epcoritamab dosing schedule, the first full dose is on cycle 1, day 15, and if patients get CRS, this is by far the most common time point to get it. And actually, but even though they get CRS, about 50% of patients do get CRS, it is usually grade 1 or grade 2. Fewer than 3% of patients had a grade 3 event, And of those patients that did have a grade 3 event, usually what that entailed was a 1 to 2 day trip for some inotropic support on ITU, and then they got better. Only one patient in the epcoritamab study actually discontinued epcoritamab because of CRS. Moving on now to ICANS. Actually, I think most people who treat with CAR Ts, I think people tend to be more worried about ICANS than they are about CRS, and I think ICANS, of the two toxicities that we see with CAR T products, is the more difficult to treat. But certainly we are seeing significant rates of ICANS with all three currently available CAR T products. And the key thing here is those patients who had grade 3 or above ICANS, because these are the patients who get really sick and need ITU support. And actually there is a significant morbidity and mortality associated with grade 3 and above ICANS. It tends to be slightly unpredictable in terms of onset. It tends to happen in between 1 and 2 weeks after the CAR T-cell infusion, and it often happens in patients who've had prior cytokine release syndrome. And you can see it can be quite challenging to manage, with time to resolution of symptoms being 1 to 2 weeks. So these are patients who are going to be sick. They're going to be needing to be inpatients nearly all the time, and as you can see, a proportion of these patients, a significant proportion of these patients actually need intensive care support, which leads to significant morbidity and in some cases, unfortunately, mortality in these patients. And again, we were very concerned when we opened our bispecific studies that we were going to see ICANS in our patients, so we were monitoring very closely for it. But actually, the other thing, just to caveat this data very slightly, I do feel that there's a trend, not just with epcoritamab, but across all of the bispecific studies, that ICANS could potentially be slightly over-reported in these studies. We were treating a largely elderly group of patients, and they had a lot of steroids as part of their ICANS CRS prophylaxis, which we'll come to in a minute. And actually, if patients had symptoms of ICANS, including confusion, you can probably imagine if you've got an 80-year-old patient that you're giving big doses of steroids to, some of those patients are going to get confused. So Martin Hutchings in particular, I know, is slightly cynical about whether these patients genuinely had ICANS. But what I'm showing you here is the reported rates of ICANS across the bispecific studies. And you can see that ICANS has been reported in all three. Odronextamab, I haven't mentioned, by the way, is the Regeneron CD3, CD20 bispecific antibody. We didn't talk about that in detail yesterday. But ICANS, even when it was reported, is primarily low grade, so grade 1 to 2, and almost always resolved in all three of the currently available bispecific antibody therapy. So I would say with bispecific antibodies, whilst ICANS is something to be aware of, it isn't something that happens frequently. It tends to be very low grade and manageable with conservative management on the ward. Very rarely does it lead to treatment discontinuation. And concern about ICANS, although it's something that you have to consent your patients for and mention to them, it wouldn't be something that would prevent me or worry me about giving a bispecific antibody to a patient. You can see that, again, if it does occur, it happens relatively quickly after that first full dose and tends to resolve quite quickly. So ICANS has been reported in bispecific studies, but at very low rates, and it's very rare to be greater than grade 1 or 2. All of the bispecific antibodies have mitigation strategies in place in order to reduce the risk of particularly cytokine release syndrome. They're product-specific and disease-specific, so the different bispecific antibodies do have slightly different dose ramp-ups depending on the disease. For epcoritamab, the mitigation strategy is, first of all, steroid prophylaxis. And for those of you in the room who haven't seen the dose optimization data that was presented at ASH, I would strongly recommend using dexamethasone as your steroid prophylaxis in bispecific antibodies, as this does seem to significantly reduce the rate of cytokine release syndrome. With epcoritamab, you start with a small dose of 0.16 milligrams on day 1, followed by intermediate dose on day 8, and the first full dose of 48 milligrams on cycle 1, day 15. With epcoritamab, we routinely use steroids. As I said, I would recommend dexamethasone for that, and we tend to use steroids in that first cycle, in other words, the first 4 doses. If patients don't have cytokine release syndrome, you can then stop the steroids. you do have the option of continuing giving steroid prophylaxis if patients do have some cytokine release syndrome. Glofitamab uses obinutuzumab on cycle 1, day 1 as its CRS mitigation strategy. And we always pre-med our patients with antihistamines and antipyretics. And it's important to adequately hydrate patients. In terms of monitoring for cytokine release syndrome, as I showed you on earlier slides, if patients do get CRS, it's highly predictable in terms of the timing. And so we recommend, and in fact the licensing recommends for epcoritamab, that on that first full dose, that patients do have a period of observation, and we tend to admit our patients onto the ward for observation. If you have a patient you're particularly worried about cytokine release syndrome, for example, if you're treating a 90-year-old patient who may have comorbidities and, for example, maybe some renal impairment or something like that, you might want to admit them earlier and monitor them on the cycle 1, day 1, just because you might have a lower threshold for going with tocilizumab, but that's very patient-specific. But certainly, cycle 1, day 15 is where it's recommended to admit and monitor the patients for 24 hours. And similarly, glofitamab has a similar recommendation to admit on that first full dose. CRS management, I've got some more slides on CRS management coming up, but basically, and I'd be interested to hear what your practice is, but my practice actually is, when I started doing these bispecific studies, I only really wanted to go in with tocilizumab when people were almost on the cusp of a grade 3 CRS event, because I was worried that it might impact the efficacy. But as we've got more confident with these agents, I'm going in early with tocilizumab, and I would certainly tend to go in with tocilizumab for a grade 2 event. I have even given tocilizumab for grade 1 CRS before for very elderly patients with comorbidities. But certainly, I think across the board, dexamethasone consider, although bear in mind that if patients get CRS, it's likely to be in that first cycle, so patients will have already had steroids as part of their prophylaxis. So I would only tend to I would keep the steroids in my back pocket, and actually I would go in early with tocilizumab for grade 1 and grade 2 CRS. Grade 3 CRS, you're definitely going to give tocilizumab. You might want to repeat the dose later on in the day. I've never seen a grade 4 CRS event with a bispecific antibody. But if those patients you will need ITU admission, they will have tocilizumab, and you may consider alternative agents if they're not responding to tocilizumab. ICANS, as I said, primarily low grade with bispecific antibodies, and I would say the management is largely supportive for these patients, with a consideration for dexamethasone for grade 1 and 2, but again, bearing in mind that they will have already had steroids as part of their prophylaxis, particularly with epcoritamab. So this is just a reminder of cytokine release syndrome in more detail. This is from slides that we produced in the UK for our bispecific program. So again, for grade 1 CRS, you can consider tocilizumab in patients. So these are patients who've got a fever but are otherwise well. I have to say I have occasionally treated patients with tocilizumab with a simple grade 1 CRS. As I said, I've treated a 90-year-old patient with EPCO before. If you're at all concerned that the patient may become unwell, there's absolutely nothing wrong with going in with a dose of tocilizumab if you're worried about your patient for some reason. And usually, in my experience, if you give a single dose of tocilizumab, the fever resolves very quickly. In case of concurrent ICANS, consider steroids, although, as I said, bear in mind that patients will have already had steroids if they're getting it in that cycle 1. And importantly, hold epcoritamab until the resolution of the CRS event. Although actually, as I've shown you, most of these CRS events do resolve quickly, especially if you give tocilizumab. So actually treatment delays because of CRS with bispecific antibodies are actually quite rare. And do remember your supportive management and make sure patients are well hydrated. By the time you get into grade 2 CRS, when people are actually dropping their blood pressure or needing some oxygen, I have a very low threshold at that stage to go into tocilizumab. And the vast majority of patients will get better very quickly with one dose of tocilizumab. If your patient has a cytopenia or is at risk for infection, you might want to consider treating for sepsis as well in some patients. But if a patient gets a fever on that cycle 1, day 15 time point, the most common cause is going to be CRS. So I would consider infection and treat it if you think you need to, but I think the tocilizumab is the mainstay of treatment. Grade 3 is where patients are requiring a bit more oxygen and are needing potentially inotropic support. I've treated over 30 patients now with epcoritamab. I've yet to see a grade 3 event, actually. So perhaps I've just been lucky, but the study suggests that grade 3 events are only happen in about 2.7% of patients. If your patient is unfortunate enough to need intensive care support, then definitely you're going to be giving a tocilizumab at that stage. You might want to repeat the tocilizumab. Remember, maximum of 2 doses in 24 hours. And you might want to consider alternative anti-cytokine therapy if CRS is refractory. I would personally, if patients are that unwell, be considering alternative diagnoses as well, such as sepsis, because as I said, grade 3 CRS is actually quite rare, and so I do think it's important to consider that this may not actually be CRS and consider treating with antibiotics, etc. Steroids, again, you can give more steroids than they've had in prophylaxis, and these are the sort of patients where you may want to give more steroids, particularly if they've got concurrent ICANS. And importantly, hold EPCO until it's resolved. You can redose with EPCO if patients have had a grade 3 CRS event, but what you should do is, if patients get a grade 3 event more than 72 hours, or if they get 2 grade 3 CRS events, then you have to permanently discontinue epcoritamab. And similarly, grade 4, which has not yet fortunately been reported in the initial phase 1-2 study, those patients should have permanent discontinuation of epcoritamab if they have a genuine grade 4 event. And again, you may well be considering alternative anti-cytokine treatments in these patients, and definitely you should consider alternative courses, bearing in mind these patients will be severely immunosuppressed by the time they get to bispecific antibody therapy and may be at risk of atypical infection. So I would have a very wide differential diagnosis for these patients and consider looking very hard for other causes. So infections, I got asked yesterday what I tend to do with infection management for epcoritamab. I treat these patients as if they're immunosuppressed. By definition, these are patients who've had 2 prior lines of treatment, and they are going to be lymphodepleted. As well as this, bispecific antibodies are B-cell depleting agents and may potentially cause T-cell exhaustion as well. So I give every patient that I'm giving a bispecific antibody acyclovir and cotrimoxazole prophylaxis, and I would monitor them closely for atypical infections if they get fevers, and definitely need to withhold epcoritamab until infection is resolved. If patients get febrile neutropenia, you should treat them as per local policies and withhold epcoritamab until neutrophils are above 0.5. I do give GCSF support, particularly in that first cycle if patients are getting neutropenic, because I think it's important to try and get the treatment in if you can. So to conclude this sort of talk on practicalities, EPCO is given weekly, cycles 1 to 3, fortnightly 4 to 9, and monthly from cycle 10 onwards. We can mitigate the CRS risk with step-up dosing and pre-medication, including steroid for CRS prophylaxis. You should monitor signs for patients with signs and symptoms of CRS and ICANS following that first full dose on cycle 1, day 15. Although, bear in mind, most of these events, if they do happen in grade 1 or grade 2. And I'm just mentioning at the end that there are recommendations on repriming for epcoritamab for what you actually do if you have dosing delays. And that depends slightly on where you are in the dosing schedule, but there are very clear repriming recommendations as to when you need to reprime your patients and what you do depending on dose delays. So just talking about this patient I presented yesterday, I've got a couple of minutes left, haven't I? More or less? Yeah. And then we'll have some time for discussion. So this is this 75-year-old patient I spoke about yesterday who had stage 4 disease, went on to have first-line treatment with R-polar chip. He had a partial response, but then had progressive disease after 6 cycles. He then went on to receive second-line GemOx, as he wasn't felt to be an autologous stem cell transplant candidate, which meant that he wasn't eligible for second-line CAR T-cell therapy in the UK. He did have a partial response after 2 cycles, but then unfortunately progressed after cycle 4. As you can see from his PET scan, he's got very extensive disease, with a bulky disease with a high total tumour metabolic volume on the PET scan, and a very high proliferative disease as evidenced by his high LDH. And there is actually evidence that I'm sure you've seen that patients with high total tumour metabolic volume are actually slightly more at risk of symptoms like cytokine release syndrome. So these are the sort of patients where you may want to keep a slightly closer eye on them and have a lower threshold for going in with tocilizumab, because patients with bulky disease are more likely to get to CRS. As I mentioned to you, he's also got some comorbidities, including renal impairment, a slightly reduced performance status, and a slightly borderline cardiac function, as well as psoriatic arthritis. And again, these are the sort of things that would make me think this is the sort of patient where actually I would be monitoring maybe slightly closer and would have a lower threshold actually to go in with tocilizumab for even grade 1 CRS. Because what you don't want to happen is you don't want that patient to lose what remaining renal function they have, and they're also going to be more, this is a sort of patient that might be a bit more challenging to support on the intensive care unit because of their slightly impaired cardiac function. So this is exactly the sort of patient where I'd have a slightly lower threshold for treating CRS early and keeping a closer eye on them. So in terms of what option I would choose, we spoke about this yesterday, and we spoke, I'm sure you remember yesterday, about the fact that this is a patient who may well not get to CAR T-cell therapy, and actually has a poor performance status, so might well have significant toxicity with CAR T-cell therapy. And actually, I would argue that a bispecific antibody is actually a very good option for these patients, as it's an off-the-shelf product with no lead-in time to actually manufacture it. So this patient did receive epcoritamab, and he developed a fever as predicted on cycle 1, day 15. He didn't have any evidence of hypotension, and he had normal oxygen saturation. So cycle 1, day 15, he's got a fever, but no cardiovascular or respiratory compromise. This is a grade 1 CRS by definition. I think it would be important to think slightly about other causes of fever, such as infection in this heavily pre-treated patient. But the most likely thing, given the timing of onset of the fever, is cytokine release syndrome. So this is a grade 1 cytokine release syndrome event, and as I said, consider anti-cytokine therapy in certain cases. So this patient's he's advanced age, 75, so I think we'd probably say yes. He's got a high tumour burden, and he's also got some comorbidities, which I would argue is actually a reason to go in early with cytokine release syndrome treatment. So this is a sort of patient where actually I would recommend going in early with tocilizumab. And although consider steroids in the case of ICANS, this patient didn't have evidence of ICANS, and this patient had already received prophylactic dexamethasone as part of their prophylaxis. So I didn't give extra dose of steroids for this patient. And you have to hold off the epcoritamab until the CRS is resolved. So thank you very much for listening to me again, and I'm very happy to take any questions.